Hi, everybody. I'm Loren Berman. We are recording this week's edition of our Zoom podcast on COVID-19 for pediatric surgeons. And I'm here today with Martha Ingram. Martha, do you want to introduce yourself?
Hi, thank you. Yes, my name is Martha Ingram. I am a general surgery resident at Emory University, doing a research sabbatical at Northwestern and Lurie Children's Hospital in Chicago, Illinois. And thank you so much for having me. I'm happy to be here.
Thank you, Martha. So the topic of discussion for today is we're trying to give everybody a sense of a snapshot of what's going on across the country in providing children's surgical care in the context of COVID-19. We had created a Google sheet that about 41 entries have been placed into to gather information about the COVID-19 response. Anything ranging from, how are you realigning your workforce? How has this affected education for your fellows and your residents? How are you approaching, postponing of elective cases, elective clinic visits? How is telehealth going? Are you making any special policies to protect pediatric surgeons who might be more vulnerable to the virus, whether it's due to age or comorbidities or being pregnant? We really appreciate everybody's data that they've entered into the spreadsheet. So what Martha has done is create a summary of all of the data we've collected so far, and we'd love to hear from her, kind of a very succinct format. I think it's hard to get a sense of what's really happening across the country when you have individual conversations with surgeons at different hospitals, and this provides a complete picture. So Martha, I'll turn it over to you to share your materials, and all of this is going to be available on the APSA COVID-19 website.
Sure. I am going to briefly give a presentation. So the summary that I'm about to provide, again, is from the open access document that you can find under the Pediatric Surgical Library. It is a live document and changing all of the time. This summary is from responses that were collected and updated as late as April 16th. At that time, there were 38 program representatives that had responded. And again, about 30 potential changes in the first month of a pandemic response, as well as 3 domains of changes were identified, which we'll go through in a little bit more detail. So first of all, we saw internal structural changes. 95% of program respondents said that they had dramatically changed their call or staffing in order to reduce healthcare worker exposure. So that meant that 55% went to more of a weekend style schedule with one rotating team. 31% had a team A and a team B that may alternate throughout the week. 14% didn't provide other details, just said they had dramatically changed their responses. And interestingly, 50% of programs reported that they were actually minimizing work duties for potentially vulnerable surgeons, so including those who were older than 65 years old, may have had underlying medical conditions, or may be pregnant during this time. The majority of programs are also limiting fellow coverage, both clinical rounding duties and operative coverage. Usually programs are alternating the fellows on service to protect their workforces. And most programs are using remote or virtual education sessions to keep up surgical education requirements. 44% of programs actually are having their general surgery rotating residents being returned back to the adult facilities in order to cover their COVID-19 patients. And then 22% of programs are sharing equipment and resources with adult facilities. The number one thing that is being shared are ventilators, either from pediatric operating rooms or pediatric intensive care units. 5 programs are actually currently reported accepting adult patients, and 13 programs reported they were planning to for regionalization purposes. 10% of surgeons said that they were covering adult services, both the acute care services or the ICU, to help with the burden. And interestingly, we saw for kind of all of these domains, I'll show this variation that occurs both interregionally across the United States, but then also within the region. So you can see that for internal structural changes, the Northwest is not necessarily having to make as many changes, but whereas the Northeast and Midwestern and Southwestern programs were reporting a lot of structural change. But then within the Southwest, you can see there are some states that are not really having to make changes, whereas others are. So Oklahoma, not very many, and Texas is definitely making evaluation changes. The second domain we saw were clinical workflow or process changes. Fortunately, 80% of programs are saying they did not need to necessarily transfer pediatric patients away from their facilities in order to protect them from adult patients who may be COVID positive. We did see more increase in using universal PPE for trauma patients. 87% reported that they were using universal PPE for all traumas. 57% reported that they were considering any trauma a PUI and therefore taking all of the risk precaution. 6% reported that they were only using N95 if there were proven PUIs, if it was a level 1 trauma, or if they anticipated having to manage the airway. Our operative cases have certainly undergone some change in terms of who we're able to provide surgical operations for right now. 30% of programs reported that they were strictly adhering to the ACS guidelines. 30% said that they were using the ACS guidelines, but also choosing on a case-by-case basis. And actually 30% said they required hospital or division leadership sign-off on the cases before they could go to the operating room. 58% of programs were saying that they were changing their use of laparoscopy in some way or another. Importantly, the majority of people are starting to use filtration during laparoscopy. 14% of programs said that they actually were minimizing the use of laparoscopy in order to reduce spread, and 8% said that they had other potential changes that they were implementing. But 15% said though they were not yet doing anything different with their laparoscopy, they were considering if they would need to start limiting it. And then something that's near and dear to all of our hearts is the increase in telehealth. So overwhelmingly, people are using telehealth for outpatient visits, and 25% of programs are actually also using it for inpatient consults. So they're dramatically limiting their in-person evaluations. I wish this number were higher, that 78% could conduct telehealth visits from home. Hopefully we can increase that to more of a 95 to 100% rate, but right now 78% in the first month. You can see that globally, most of the regions are making clinical flow changes with less variation compared to the internal structural changes mapped. Our last domain that we saw changes in include the COVID safety and prevention domain. So 67% of respondents said that there was universal masking occurring in their facilities. A third of hospitals reported they were only having staff wear masks all the time, but 55% said staff and families. I expect now that number has probably changed. So we'll see in the next update what that looks like. 84% of programs are actually limiting patients to 1 or sometimes 0 allowable caregiver visits. By and large, everyone is saying that, patient caregivers or visitors have to be pre-specified and cannot change in order, obviously, to limit adult exposure, both to healthcare workers and patients for COVID positivity. And 57% of programs were actually cohorting PUIs with COVID positive patients. In terms of testing, unfortunately, 75% of institutions are still having to wait over 12 hours to get results. This number changes all of the time, and so we'll see in the next week. I suspect that time frame has dramatically changed for some institutions, but maybe not all of them. And it will also be interesting to see what serologic testing how it starts to pop up for the pediatric hospitals across the country. It also looked like about a third of hospitals at the time that this analysis was done are testing COVID-19 patients before going to the operating room. It looked like 83% were testing all patients for COVID, and only a couple of hospitals who said they were testing specified that they were not testing emergent cases, but otherwise would test patients. And by and large, 75% of institutions reported that they were sterilizing or reusing N95 masks. The most common policy is to reuse it until it was soiled or dirty or unable to be used, sometimes up to a week. The most common modes of sterilization for those that were sterilizing are UV light, followed by hydrogen peroxide. Here, some of these questions were towards the end of the database, so that's where we see kind of a little bit more dropout in reporting. But we can see that the Northeast and the Midwest and West and Southwest are all having a good number of safety and prevention changes that are being implemented in their facilities. So just out of curiosity, I wanted to see kind of what the last update date in the spreadsheet was relative to the expected surge. So you can see that there's a high amount of variability. On the x-axis, these are the kind of code names for the institutions. And then on the y-axis, you see the calendar dates from the end of April all the way through May 3rd. And essentially the take-home point is that people are reporting their changes in a wide variability of whether they're expecting to see a surge happen really closely soon in the near time frame, or whether they are still expecting the surge to happen a month from now. This data for the expected surge date is from the IHME website, and some of these surge dates have been changing over the next few months, so we will continue to see how this graph evolves over time. So in summary, from this first month of the pandemic response, we found that there are significant changes occurring in staffing in order to decrease healthcare worker exposure. There is significant change in the patient care areas and clinical flow. There globally is an increase in use of telehealth. The sharing of staff and equipment is variable and largely institution specific. And some of the COVID-19 safety measures that I would have expected to see a little bit higher were less frequently reported than expected. However, ultimately, the changes in centers are still very dynamic, and so we'll continue to need to take snapshots over the time. So this is just, as Dr. Berman said, update the spreadsheet. So here you can find it under the Pediatric Surgery Library or likely in your inbox. So make sure you update the fields, and we'll continue to do more report updates in the near future.
That's great. Thank you so much, Martha. I think you've done a really fantastic job in summarizing a lot of complex information, and we will make this presentation available on the website so anyone can look at it. I have personally found this really useful when certain questions are being discussed locally, such as one that's come up more recently, I think, for a lot of hospitals is, you know, we're now 5 or 6 weeks into the pandemic. When it started, we canceled everything. Some of those things that we canceled were not emergent, obviously, but they were sort of urgent or semi-urgent, you know, a symptomatic inguinal hernia, a pilonidal cyst that keeps flaring up and needing to be drained. So we're now, at least at my institution, we're starting to talk about bringing back not elective cases, but sort of these semi-urgent cases that have become more urgent now that we're 5 or 6 weeks into things. So in the most recent iteration of the spreadsheet, we did add some questions about how is your hospital approaching ramp up? And I think there's a lot of different conversations going on across the country, depending on kind of what the local environment looks like in terms of the COVID surge timing, about how we're going to ramp volume back up. So if you have not updated your line of data for your institution, please access the Google Sheet and do so. And if you haven't filled it out yet, we would love to get more data from around the country, because the more we get, the richer the resource is. And I think we can all learn a lot from each other. So this is also sort of a preview for early next week. We're going to be recording another Zoom podcast to look at a sort of a systematic approach to how do we ramp volume back up when the time comes. And we'll be hearing from Grace Mack and Mark Slidell, who have done some work in that area. So please continue to stay tuned, and we will continue to provide regular summaries of the information that we get from all of you. So thank you for continuing to participate and spreading the word, and stay safe and healthy.